Good afternoon. Today we're going to discuss alterations in immunity and inflammation. We already talked a little bit about the inflammatory cascade through the innate immune system in the first PowerPoint. Today we're going to do emphasis on hypersensitivity reaction and autoimmune diseases. So what is a hypersensitivity reaction? It's basically an undesirable reaction produced by the normal immune system that includes from type 1 to type 4 hypersensitivity reaction. It's basically a harmful reaction. Is an autoimmunity. So remember that we have a part of our immune system that is a self or self antigen that the immune system is able to recognize and avoid the immune system to be active and uh, act against it. When this mechanism fails, then or the immune system is able to recognize the self antigen as self, then it will transform into a non-self or antigen, and the immune system um, will attack it. So, in other words, this non-self non-self antigen will become immunogenic. So hypersensitivity, in other words, is an autoimmune reaction as well. So we have several types of autoimmune reactions. There is type 1 allergy, which is mediated by IgE, and is an immediate hypersensitivity reaction. It's a fast response that occurs within minutes rather than hours or days as the others. Has the release of mastocytes, and remember that in the mastocytes degranulation there is the release of histamine, and histamine type 1 will be present in bronchioles producing bronchoconstriction. So basically it's the release of these vasoactive biomolecules that will produce anaphylaxis. Okay, so that's the mechanism of allergy. Autoimmunity, I already explained, that is no more than a disturbance of the immunological system. So it's also a disturbance of tolerance. If you remember, the reason we recognize an antigen as self is because of tolerance. So loss of tolerance is also an autoimmunity. What is alloimmunity? Alloimmunity is no more than when the immune system of one individual produces an immunological reaction against the tissue of another individual. So it's your tissue against the tissue of another individual. Then we have homeostasis. An example, for example, of autoimmunity is transplantation, blood transfusion. So when you're receiving a blood transfusion from another patient, or a transplanted organ from another patient, is the reaction of your tissue against the tissue of the other individual. We talked about what is homeostasis. Remember that the body and all the cells and all the compartments must be in balance. And that balance or steady state is called homeostasis. So let's do again one by one. We have a hypersensitivity reaction type 1, which is again other ways to describe it is the atopy, anaphylaxia. The best example for type 1 hypersensitivity reaction is asthma. But remember that when there's production of eosinophils and IgE, there's allergic or parasites reaction. That's important. Okay, so it's the most common. It involved either environmental allergens such as pollen or dust or roaches or any type of allergen that is in the environment. Um, it's also involves the degranulation of mastocytes. This is the most important component of the immune system. The activation of the mastocytes, degranulation of it, release of vasoactive mediators. And the primary mediator that is released is histamine. And if you remember, histamine has histamine 1 and histamine 2. And in the histamine 1, there's production of bronchoconstriction. That's the reason why there is the best example for this anaphylaxis or hypersensitivity reaction is asthma. In another example would be since histamine 1 is also present in the skin, the presence of atopy. It could be related to rhinitis. It could be related to atopic dermatitis. Um, so another secondary mediator that is released in hypersensitivity reaction type 1 is the leukotrienes and prostaglandin. Remember, those are cytokines, okay? And very important that all these cytokines will produce vasodilation, increased capillary permeability, and diapesis of neutrophils. And with increase of vascular permeability, there is production or presence of edema. So in type 1 hypersensitivity reaction, you would see bronchoconstriction, vasodilation of the vascular space, increased vascular permeability with edema, increased blood flow, and diapetesis or chemotaxis of neutrophils, attracting more cytokines or pro-inflammatory mediators to the area of inflammation. Examples of type 1 hypersensitivity reaction. I told you already that is most commonly asthma. So the best example here would be asthma, but others could be allergic conjunctivitis. That remember, this is bilateral. It's a systemic condition, so both eyes are affected. Patients would have itchy or pruritus in the eyes. There is watery discharge in the eyes, along with injection of the conjunctiva vessels. Another example will be rhinitis, allergic rhinitis, that the patient would have rhinorrhea. They would have itching as well, pruritus of the nostrils, sneezing, etc. Asthma, you know that this is the hypersensitivity reaction, is the hyperresponsiveness of the airway by bronchoconstriction. There is activation of the goblet cells, production of mucus, and patients would have bronchoconstriction, in expiration, and wheezing. Atopy is another, or atopic dermatitis is another manifestation of type 1 hypersensitivity reaction. Patients will have, in the neonate, for example, is more more commonly present in the extensors, flexures of the body, such as in the wrist, in the behind the popliteal area, around the neck. Very itchy, redness associated with oozing as well. In the GI, patients could manifest type 1 hypersensitivity reaction by food poisoning, but it's not related to bacterial infection, but related to allergic reaction to certain particles of the food. And it could be manifested with bloating, abdominal pain, nausea, or vomiting. And in the skin, besides the atopic dermatitis, patients could have urticaria, hives, or even flare reactions. So how do you test the patient? You could do allergy sensitive skin test. You could also measure serum IgE. Um, in addition, what you could do to a patient that has hypersensitivity reaction type 1, it's what's called desensitization. And desensitization is no more than administering the patient small quantities of a particular allergen to desensitize the patient. Now, the major risk of this is basically producing an anaphylactic reaction. So the desensitization is recommended to be done in a very controlled environment. And basically the mechanism or pathophysiology of this is what's called a blocking antibody. Once the patient received small quantities of the allergen, patient will start releasing a large amount of antibodies that would block this immune reaction. type 2 hypersensitivity reaction is what's called cytotoxic or antibody dependent. The antibodies that are released are IgM or IgG. Remember that IgM is for primary response, is for acute diseases, and IgG is released in the secondary response and is for prior exposure of a disease process or chronic. They do bind to an antigen on a target cell, which is actually a host cell that is perceived by the immune system as foreign. That leads to destruction of the cell by the histocompatibility complex. Um, so basically, what happens is that a specific cell or tissue becomes the target. So the antigen will attach to a specific tissue. For example, platelets. If there is an antigen that will target or will bind a specific tissue, such as the platelets, patients could have thrombocytopenia. It is cytotoxic, so it involves activation of the complement cascade. It involves cytolysis, so destruction of the cell. It does involve as well phagocytosis. So again, all of this mechanism of type 2 begin with an antibody binding to tissue-specific antigen, and that's the key of type 2. So tissue-specific antigen binding. So the antigens will attach to a particular tissue and then will be destroyed by the antibody with an activation of the complement cascade, in this case the classic pathway, because remember the classic pathway has the antigen antibody complex formation, results in lysis of the cell. Examples of this could be hemolytic disease of the newborn, for example, which is the ABO incompatibility. What happens in this disease, just to explain a little bit about that, is even though it's in one of the next slides, maternal IgG antibodies with a specificity for ABO blood group pass through the placenta to the fetal circulation, where they're recognized as foreign and being hemolyzed. So basically, it's the hemolytic anemia because of Rh disease. If the fetus has an Rh positive and the mother has an Rh negative, first what happens is that there's a primary response. So the blood or the immune system of the mother recognize the positive Rh of the baby as non-self, will create antibody, and maybe the first baby is born normal, but after the first delivery, when there is the activation of the immune system and contact of micromolecules of blood between the fetus and the mother through either placenta or through labor, now when the mother gets pregnant again with another baby that is Rh positive, now the immune system has memory and remember this positive Rh as foreign and will attack it, producing hemolysis. So that's the reason why there is a vaccination. Okay, so basically, the baby will be with hyperbilirubinemia, jaundice, hemolytic anemia, even up to cagnicterus, which is a life-threatening situation with seizures and possible mental retardation. It is diagnosed with routine antenatal, which is before born, antibody screening blood test, which is indirect cum. Okay, and basically either treated with phototherapy, exchange transfusion, but for prophylaxis, there is a vaccination for that. Now there is type 3 hypersensitivity reaction, which type 3 will be immune complex disease. And type 3, there is antigen antibody immune complex formation. So in type 2 is tissue specific. These specific antigens that are attached to a particular tissue and produces destruction of that tissue by lysis, activation of the complement cascade. And examples of those are autoimmune hemolytic anemia or ABO mismatch or hemolytic disease of the newborn. There's also phagocytosis, as I explained. Another example of this is the antibodies against platelet, like HIT, for example, heparin-induced thrombocytopenia, will be a type 2 hypersensitivity reaction. There's also initiation of the complement cascade and activation of neutrophils to the area of infection. And another example would be the antibody-dependent cell will activate the natural killer cells, and if the if the cells are not destroyed completely, which is the most common uh, way of presentation, then it could stay in malfunction. So if it doesn't get destroyed completely, there is direct antigenic determinants that will produce malfunction of the cell. And this is the case of hyperthyroidism. And for hyperthyroidism, let me give you a brief pathophysiology of the disease. Basically, remember that it's characterized by hypermetabolism and elevated serum levels with free thyroid hormones. And if you recall, the symptoms are tachycardia, fatigue, weight loss, nervousness, tremor, exophthalmos, goiter, etc. Um, so the most common causes will be um, Graves' disease, thyroiditis, multinodular goiter. Um, but the actual pathophysiology of the disease is serum T3 usually increases more than T4 uh, because there is increased secretion of T3 conversion to 3,4 in peripheral tissues. Um, that includes in Graves' disease. Is as an autonomic disease that the patient would have a solitary thyroid nodule. Patients could become thyrotoxic and develop the same manifestations of hyperthyroidism, which again could be nervousness due to excess of adrenergic response, hyperactivity, sweating, fatigue, increased appetite, weight loss, weakness, um, diarrhea could be, um, alterations of menstrual period. Um, in elderly, it's a little bit more atypical. Patients, instead of being nervousness and with palpitations, could present with depression and even dementia. Atrial fibrillation is another way of presentation. Thyroid storm, you would see this in acute care, how patients will present with tachyarrhythmias, and you would see the treatment in pharmacology, which is based on methimazole or PTU, beta blockers, radioactive iodine, or surgery. Now, in type 3 hypersensitivity reaction, again, is caused by immune complex formation in the circulation that then are deposited into the tissue. The difference between type 2 and type 3 is that, remember, antigens are attached to a specific tissue. And type 3, the antigen is formed, then released into the circulation, and then is deposited into the tissue. There is complement activation. It is not organ specific. There is also phagocytosis involved, but the major key point here is immune complex formations. Examples of hypersensitivity reaction type 3 is serum sickness, Arthur's reaction, rheumatoid arthritis. You have post-streptococcal glomerulonephritis, lupus nephritis, systemic lupus. In addition, hypersensitivity pneumonitis. So there are many. Going to briefly explain, a few of them. So what is serum sickness? Basically, serum sickness is a type 3 hypersensitivity reaction that results from the injection of foreign proteins or serum. Reactions are secondary to the administrations of non-protein as well. The pathophysiology of serum sickness is basically after the initial exposure to a foreign antigen in the absence of a pre-existing antibody, the serum sickness can develop within 1 to 2 weeks. That's primary exposure. Now, upon subsequent exposures, serum sickness develops sooner, which we already explained in adaptive immune system. The disease appears as the antibody formation begins, and the pathogenesis of serum sickness is related to protracted interaction between antigen and antibody in the circulation, with antigen-antibody complex formation in an environment of antigen excess. So the immunological interactions observed in serum sickness occurs when antigens are capable of remaining in the circulation for long periods of time. There is a high expression of endothelial cells that are attached to monocytes and macrophages and other pro-inflammatory mediators that are highly released. Then at this point, complement cascade is activated. Etiology of the serum sickness could be an antitoxin, could be an antivenom, could be a vaccination, could be hormones or even streptokinase, or even it could be cephalosporins, ciprofloxacin, so it could be any antibiotic. The clinical presentation of serum sickness develops 1 to 3 weeks after the administration of this foreign material. Patients could develop fever, malaise, which is the highest of the symptom, cutaneous eruptions, arthralgias, gastrointestinal complaints, headache. So, but the most common would be a rash and fever and malaise. How do you diagnose? Well, basically by the presence of cryoglobulinemia. Patients would have or could present with dermatitis, purpuras. Laboratories, patients could come in with leukocytosis. Erythrocyte sedimentation rate is elevated. Remember, this is a marker of inflammation. Patients would have proteinuria, hematuria, IgG would be released. And the treatment, even though we're not concentrated on treatment until pharmacology, basically withdrawal of the offending agent is the best. But medication-wise, you could give non-steroidal anti-inflammatory drugs such as NSAIDs. Remember, this is an inflammatory reaction. You could give antihistamines, you could give corticosteroids. Now, let's talk briefly about Arthur's reaction, which is another type of hypersensitivity reaction, type 3, which is immune complex formation. So antigen-antibody complex are formed in the vascular walls, but it could be present also in the pleura, in the pericardium, in the glomeruli. So patients could also get an Arthur's reaction due to vaccination, such as tetanus toxoid or diphtheria. Patients will present with local manifestations of vasculitis up to necrosis of the skin and thrombosis. So again, this is basically a repeated local exposure to an antigen It could be due to inhalation. It could be due to vaccinations. In addition, it could be another example of orthos reaction could be celiac disease. And celiac disease is an immunological mediated disease that is genetically susceptible. Patients would have intolerance to gluten and results in mucosal of intestine inflammation that causes malabsorption. Patients will present with diarrhea and abdominal pain, and the diagnosis is basically by biopsy of the small bowel. Another disease process present in serum sickness is Raynaud phenomenon. That is no more than a vasospasm produced. It's another type of vasculitis. Type 4 hypersensitivity reaction is delayed type. It's cell-mediated immune memory response. It's also antibody independent. Does not involve an antibody and is delayed. So the antigens will present the cells to the immune system by macrophages. There is also activation of the complement cascade and release of cytokines. In addition, there is an activation of CD8, remember the natural killer cells, and that will destroy the target by releasing hydrolytic enzymes. Examples of type 4 hypersensitivity reactions, rheumatoid arthritis is there, Hashimoto thyroiditis, diabetes, contact dermatitis is there, transplant rejection, multiple sclerosis, for example, is also present in there. This is the picture of interactions of type 1 hypersensitivity reaction, the release of interleukins, the degranulation of mastocytes producing histamine release, and airway hyperresponsiveness. You have a table with the difference of all types of hypersensitivity reaction. We haven't discussed type 5, but type 5 is a mixture of and is receptor mediated. Examples of those are Graves' disease and myasthenia gravis, but it could be present in type 2 and type 3 as well. Now, what is autoimmunity? Remember that our body has to be able to recognize the self and has to be able to create tolerance against the antigens, the self antigens. When there's a breakdown of tolerance, homeostasis is lost and autoimmunity is created. So it's a loss of tolerance. And the original insult could be anything. It could be a genetic malformation. It could be an infectious process. It could be a hapten. It could be anything that will trigger the autoimmune response to be activated. Now, examples of this would be systemic lupus. And if you recall, systemic lupus is a chronic multi-system inflammatory disorder, autoimmunity, that occurs in young women. The common manifestations will include arthralgias, malar rash, pleuritis, pericarditis, nephropathies, and even hematological disorders. Remember that the diagnosis is by a criteria, ANA, as well as anti-Smith antibody, anti-cardiolipin antibody, and lupus anticoagulant that is present. 70% occurs in women. Lupus also could be related to exposure or environmental trigger, such as drugs. And these medications could be hydralazine, procainamide, isoniazid, ultraviolet light, other infections, which is called syndrome like lupus. Patients would have joint manifestations, they would have cardiopulmonary manifestations, even neurological manifestations. They could present with subarachnoid hemorrhage, with seizures, psychosis, renal manifestations, which is basically nephropathies with proteinuria and red blood cells, cast, hematological manifestations from thrombosis to thrombocytopenia, GI manifestations that could be related to impaired bowel motility and abdominal pain, even peritonitis and bowel perforation. Remember that we have a clinical criteria as well as antibodies that are present. We talked about the clinical criteria. Also, patients will be positive 98% to ANA. There's anti-cytoplasmic antibodies present, and those include ROSSA, LASSB, anti-Smith antibody. You don't need to memorize that. And the treatment is based on anti-inflammatory mediators, NSAIDs, anti-malarial, corticosteroids, and immunosuppressants that we will talk about in pharmacology. Then another way of presentation of type 4, another example would be graft rejection of transplant. And if you recall in the second video, I explained how important are histocompatibility complex, HLA antigens, for the treatment or rejection of transplant. So complications of transplantations could be rejection, infection, renal insufficiency, cancer, and even atherosclerosis, but we will concentrate on rejection. That could be hyperacute, acute, or chronic. In hyperacute, that occurs within 48 hours of transplantation and is caused by pre-existing complement fixing antibodies. So there's pre-sensitization of that. It's characterized by small vessel thrombosis and graft infarction. And there's no treatment effective for this. So it's immediate. There's persisting antibodies. And those are IgG and IgM. Acute rejection is the graft destruction after transplant and is caused by T cell mediated delayed hypersensitivity reaction. Acute rejection is different from hyperacute and accelerated rejection because it is mediated by de novo, meaning that for the first time, anti-graft T cell response, not by persisting antibodies. Okay, vascular integrity is maintained, but the patient will present with various degrees of hemorrhage, edema, and even necrosis of the transplanted organ. And chronic rejection could take months to a year, and it could even present without fever. Causes are multiple and include early antibody-mediated rejection, inflammatory damage, and fibrosis. So there's ischemia, there's reperfusion injury, there is infection, there's vascular factors such as necrosis and fibrosis. Now, for the tissue graft, there is allograft, which is transplantation of cells, tissue, or organs from a genetically non-identical member of the same species. So, giving your organ, or say obtaining an organ from a non-identical member of the same species is an allograft. Xenograft is a transplantation of cells, tissue, or organs from one species to another. So a xenograft is when you received a porcine valve, for example. Autograft is when you receive or when you transplant, for example, skin from one part of the body to another because of burn. Isograft will be graft or of tissue between two individuals who are genetically identical. So the isograft will be between twins. Allograft will be between two humans when you receive a heart, when you received a liver, etc. So allograft, when you receive an organ from another human. Xenograft, when you receive an organ from another species, which is an animal. Autograft, when you transplant a part of your body into yourself. And isograft will be between twins. I explained already the ABO and RH system reaction. Now, there's other type of immunodeficiencies, and these are the primary and secondary. I'm not going to spend time explaining all of them. You have them listed. Okay, and basically they could be a mixture of types of hypersensitivity reaction. But in all of them, there is complement activation, there is phagocytosis and lysis. Secondary could be, for example, from a psychological stress to normal physiological conditions, malnutritions, malignancies, and even medical treatments that we give in the daily basis. Now, the one that we will discuss briefly, even though you have an assignment in this unit to read that is important for your exam, is HIV. And HIV, if you recall briefly, is an infection that results from one of two similar retrovirus, which is HIV-1 and HIV-2, that destroys CD4 lymphocytes and impairs cell-mediated immunity, increasing risk of central infections and cancer. The initial infection may cause nonspecific febrile illness. Risk of subsequent manifestations related to immunodeficiency is proportional to the level of CD4 lymphocytes. So HIV can directly damage the brain, the kidneys, the heart. It could cause cognitive impairment, renal insufficiency, and even cardiomyopathy. Manifestations will range from asymptomatic carriage to AIDS, which is defined by serious opportunistic infections or cancer, or when the CD4 is less than 200. HIV infection can be diagnosed by antibodies, nucleic acid HIV RNA, or an antigen, which is P24 testing. Screening should be routinely offered to all the adults and adolescents, and the treatment basically is based on suppressing HIV replication by using a combination of 3 or more drugs that inhibit HIV enzymes. So, if you recall, the transmission is by blood, drug abuse, heterosexual, homosexual, maternal child transmission as well. It's an RNA retrovirus, and these enzymes that we were talking about that you should target, it's a transcriptase that converts the RNA into a double-strand DNA, integrase that will a new DNA is inserted into the infected cell, producing lysis and apoptosis. So, in addition, target, as I explained already, the antigen-presenting cells are also affected, the dendritic cells, the macrophages, the thymus. If this is a neonate, it will have impaired adaptive immune system activation. And if this is a neonate or an infant, bone marrow is still immature, so the disease process will be more exaggerated. Two main consequences of our IV infections will be damage to the immune system, specifically depletion of CD4 lymphocytes. Remember that CD4 lymphocytes are involved in cell-mediated and to a lesser extent in humoral. So there is direct toxicity effect of HIV replication if your immune system is competent. Cell-mediated immune cytotoxicity, thymic damage, and impair of lymphocyte production. Infected CD4 lymphocytes, remember that they have a half-life of 2 days, very, very short. The humoral system is also affected. There is hyperplasia of lymph nodes, so the patient will present with lymphadenopathies. There is abnormal elevation of immune activation that may be caused in part by absorption of component of bowel bacteria. Other tissues could be affected as well, such as the brain, the genital tract, the kidneys, um, and several other compartments such as the CSF. As the disease progresses, the risk and severity of opportunistic infection um, is a risk. So, for example, if the CD4 count is 200, um, patients would have the risk for pneumocystis jirovecii, toxoplasma, and cryptococci meningitis. If it's less than 200 for cytomegalovirus, um, Mycobacterium avium. If it's less than 50, uh, patients could have even cancer. That's without counting fungal infection systemically. We talked about the manifestations. How do you diagnose? Is basically an HIV antibody testing and by nucleic acid amplification assets, which is the viral load. So by ELISA, which is more sensitive than specific. More specific is Western blot. And then basically you would follow CD4, CD8s, and viral load. And treatment is going to be left for pharmacology, but it's a combination of antiretroviral drugs that sometimes are called ART or HAART, and prophylaxis of opportunistic infections based on the level of CD4 count. This is no more than a representation of the host cell being attacked by the HIV and the activation of CD4s and CD8 and formation of new virins. So serology could be negative. The patient could be asymptomatic because there's a window period. In the early stages, besides the symptoms that I described, there is flu-like symptoms, diarrhea, fatigue, and night sweats. Remember about the opportunistic infections, and I explained about the antiretroviral therapy. Vaccination, you must avoid live dormant virus vaccination, such as MMR, for example. Patients could develop a type of hypersensitivity reaction. We already described graft versus host disease. They could also have superimposed B cell deficiencies, such as lymphomas and leukemias superimposed. Another therapy for not only patients with HIV, but patients that have graft versus host disease is the immunomodulators. Besides NSAIDs and steroids, bone marrow transplantation, also if they have any type of hemolysis, fresh frozen plasma, and gene therapy. And this concludes the end of this presentation.